Thank you very much. Thank you for inviting me. No disclosures to say. I will be taking a very practical approach. I believe most of you are infection control professionals. And just by a raise of hand, I'll ask a few questions. How many of you do surveillance for hospital-acquired infections? Good, majority. So you'll understand what I'm going to talk about. So first, I'm going to just give an overview of goals and objectives of antibiotic stewardship. And I'll give you very specific examples, really based on local data on C. diff, UTI, respiratory tract infection, and surgical site infection. And I'll end up with the 10 commandments of antibiotic stewardship. So, antibiotic stewardship. Studies year after year after year tell us that antibiotic usage is inappropriate or unjustified in 30 to 50% of cases in healthcare institution, but of course not at your hospital. What are the risks? Side effects, superinfection, antibiotic resistance. We just had a flagrant example just presented. What can we do? Essentially, there's two major approaches. The one that's really proven popular and effective is that of prospective audits with intervention and feedback. And the second one, which is restricting antibiotics requiring pre-authorization. And I'll show you examples of that. So when did I begin involved as in antibiotic stewardship? Well, when I was a resident. In fact, we had a number of antibiotics that required an ID consult, imipenem, metronidazole, tobramycin, and third-generation cephalosporin. Well, you want to know, we don't use imipenem anymore. Metronidazole, we'd be so happy that everyone uses metronidazole. It's a few cents. Tobramycin is not used anymore because of nephrotoxicity that much. And third-generation cephalosporins are now very often a first-line agent. All of this to say that whatever was true 30 years ago is completely false nowadays. And what ended up is we ended up arguing at 3 in the morning in the ICU with the surgical resident and the ID fellow, no, you can't use Flagyl, yes, you can use Flagyl, and then it ended up in a little fist fight. Well, what is antibiotic stewardship? It's using antibiotic for a right indication, for a right choice, right dose, the right route, and the right duration. And how did I really get interested from infection control into antibiotic stewardship? Well, most of Canadians are now aware, certainly people in Quebec, of the major outbreak we had of C. diff published in mid-2000, where we were 12 hospitals in Quebec, and there was a major province-wide outbreak. About 2.2% of patients were acquiring C. diff in hospitals in the early 2000s. And following that crisis, this is a paper published by Valiquette, who in the first few months tried to install infection control measures, but as you can see, the rates stayed very high. But when they introduced antibiotic stewardship intervention, the antibiotic consumption went down by 20 to 30%, and their rates went down. And this is my center in that outbreak, another hospital, and I reviewed all the cases we had submitted of C. diff. And you can see that the reasons people were getting antibiotics were on the y-axis, but you can see for a certain number of conditions, antibiotics were not indicated in about 20% of cases, and the choice was another, again, inadequate in the other 20% of cases. I mean, just by looking at that, you could say that I could have prevented maybe 20% of cases of C. diff. Now, the thing you don't know about this slide is this hospital had a stewardship program that was active going on for about 10 years. So it was probably very good results. And then I moved to another hospital, and this is where I work actually, which is the McGill University Health Center, and you can see the rate of C. diff going up and up and up as soon as I arrived there. Maybe I brought it from my other hospital. And this study published a little bit around the same time that looked at all the cases of C. diff, over 200 patients, and 3/4 of patients had received at least one unnecessary dose of antibiotic. 45% of all antimicrobial days were not indicated. And what were the most common reasons? UTI and pneumonias. So if you want to do stewardship, you have to look at those two things. Overall, same as what I showed you locally, about a quarter of the patients with C. diff had received completely unnecessary antibiotic. And I can tell you that every year I see some patient dying from C. diff that should not have received antibiotic. So, what did I do with this rising C. diff rate at my new hospitals? Well, we made a plan of action, of course, isolation and precautions, cleaning and disinfection, management of stools, wishful thinking to have new rooms, single rooms, eventually happen. But key in the center of this plan of action was antibiotic stewardship. And we tried to reduce a little bit this attitude that we seem to be doing at our center. Well, how was the antibiotic stewardship at my hospital? Well, we had no program, we had no pharmacist, had C. diff, MRSA, VRE everywhere, and we were using carbapenem, vancomycin, timentin, and now piptazo all over the board. So it was really square one. Well, what's square one? The first thing you have to do is to have local guidelines, and we did not have local guidelines then. And you have to have those guidelines approved by your doctors, your peers, even by your ID microbiologist colleagues, because some of them are the culprits. And you want to implicate all those departments and doctors in the choices, and it always helps to have your local data, pathogens, especially from your surveillance, and to have sensitivities and antibiogram. So, first trial of audit and feedback. So we went to a hospital, which was a neurological ward, and for a month we surveyed everyone on antibiotic. There were 32 patients on that ward that were put on antibiotics. Green is good, red is bad. And you can see that overall, it was good in only 31% of cases. Now, you have on the top graph the disease for which antibiotics were quote-unquote given. The bottom left, the type of antibiotics, and the bottom right, the type of doctors. Well, they pretty much match. So you could see that we were giving, for pneumonia, a lot of vancomycin and piptazo. For UTI, we were giving a lot of Cipro. But more importantly, in the UTI, most of these patients did not have UTI. What was the problem? Well, the problem was the treatment of asymptomatic bacteria. At that time, urinalysis was done by the bedside. We couldn't find any record, so physicians couldn't even look at the urinalysis, so we couldn't even see there were white cells in the urine, and we had to say no pyuria, no UTI. They didn't distinguish 10 to the 7, 10 to the 6, or 10 to the 8. A coag-negative staph was treated the same as E. coli. And what was the first choice? Cipro. Well, which is the antibiotic most associated with Cipro? With C. diff? Quinolones. Pneumonia being treated with normal chest x-ray, and surgical prophylaxis that went on and on and on for up to a week. And finally, meropenem was often used as a first-line antibiotic. So what did we do? We did audit and feedback. The month after, I gave grand rounds to the residents and the fellows, and you can see right after the beginning of the year, we went from 30% to 60 to 70%, and we continued our audit and feedbacks until P4, where it dropped. When is P4? Administrative period. July 1st. All the residents had changed. And all the work we had done came back to square one. So it took us a few months to realize that, and then we gave rounds again, and you can see that the feedback came back up. So continuous need to continue this audit and surveillance to maintain the success. So what is your role in this? Well, how many of you do surveillance for urinary tract infection? Okay, a little bit less. UTI is the most common, hospital-acquired infection. Well, I'm sure you look at all positive urine culture, right? And how often do you find the criteria that defines a urine culture as being a UTI? And then, well, lastly, let's look at if this patient is on antibiotic, and is there a match or a mismatch? So I've asked my ICP to document all the review all the urine culture. Look, we use the NHSN criteria, but IPAC has very nice definitions now for long-term care. We document symptoms, we look at treatment, and then we make an assessment whether it's appropriate or non-appropriate. And I review every case over that time period. And this is off software where you can see I chart the urinalysis on the top left corner, the symptoms on the right left bottom, and whether antibiotics are given, and which antibiotic, and whether it was appropriate or not. And if they have a Foley, I even have in the top right the reason for the Foley. So we can at the same time tackle whether we could have prevented this UTI or not, and whether it should have been treated or not. And so finally, we find that a lot of those asymptomatic bacteria are being treated for nothing. But to start with, why was the urine culture done anyway? And so we reviewed a month of consecutive urine cultures on surgical ward, and you can see, first of all, we couldn't find why the urine was done in about 14% of cases, and anywhere between 25 and 60% of cases, the culture was appropriate, and thus being inappropriate in about a quarter to half the times. And why were the cultures done, and why was it inappropriate? And that's where you might be important in your education and teaching program. I don't know how many nurses believe that foul-smelling or cloudy urine is a sign of UTI. Dark urine as a sign of UTI. People go in urinary retention. No, urinary retention is a predisposing factor to UTI, but it's not a sign of a UTI. Having deposits, crystals in the urine is not a sign of UTI. You wouldn't believe how many people do urine culture when you remove a Foley. You shouldn't be doing a culture when you remove the Foley, because that's the treatment of a positive urine culture on a Foley. And many, many other reasons why urine cultures were inappropriate. And many of my team infection control professionals educate the nurses as to when to do appropriate cultures. And what was the results? So you can see here roughly that about out of those 344 culture, about, I can't see the percentage, but about a third of them were at least asymptomatic bacteria, and about 40% of them ended up being treated unjustified. So I refer you to this wonderful produced by IPAC Canada. It's a free PowerPoint that you can use to do your teaching, which says, let it be your symptom-free P, let it be. And so we applied this in our long-term care at one of their long-term sites. This is actually a presentation that France Nadon is doing at the meeting today. And you can see that we still have a lot of asymptomatic bacteria in yellow being done, but I want you to look at the gray part. We've been able to decrease by half the number of asymptomatic bacteria being treated over the last year in these people, with a constant number of UTI in blue. So that was for UTI. I think that's one area where you can be very, very useful. What about respiratory tract infections? Well, where do most respiratory tract infections end up? Well, in emergency. And a lot of times we would do stewardship on the ward, and they say, well, the antibiotic was started in Emerge, so let's go see an Emerge. So I'm sure that after SARS, MERS, H1N1, maybe some of you do some surveillance, whether to see precautions are applied in emergency room. And we do that. We've been doing that for the last 4 to 5 years. But I asked my ICP, well, you know, let's look at all our flu-like syndromes, and can you tell me if they've been on antibiotics or antivirals, and do they need them? So we did the same principle. This is a week of usage of antibiotic in our emergency room, and guess what? Same thing as that other unit, about 60% inappropriate. Here, it was not so much the indication that was inappropriate, it was the choice. And same red and green, and antibiotics below, conditions above, and so you can see using PIP Tazo for pneumonias, using Avilox or moxifloxacin for COPD, and using Cipro for UTIs. And it's by chance that the most frequent antibiotics were used for the most frequent conditions. And what was the problem? Well, moxifloxacin is not our first line for COPD. We'd rather have them use amoxicillin, Septra, or doxycycline. For COPD exacerbation, same thing. And we were lucky to have that respiratory virus PCR that the previous question, one of the ICP from Newfoundland was asking. We have the chance of having this test 24/7 within our hospitals, so it's readily accessible to our emergency room staff, and you're all dying to know, does it change antibiotic usage? And I'm going to just go quickly over this. So is it a virus or a bacteria? So does it change something if we know that it's a virus? So this was published a few years ago. And it's small print, but look at the red box on the right. So the first thing is you can see for all the people with positive tests, about 70% of those people in emergency or admitted to emergency were prescribed antibiotic. Fine, they're sick, they need admission, you say that's fine. But what happens after the result? Well, after the result, you would say it's a virus, maybe they can stop antibiotic, but it was stopped in only 20 to 30% of cases. So in other words, a good 50% of patients with confirmed viral respiratory tract infection still are on antibiotic despite having this test. And so this is an observational study, and I truly believe that, as Jérôme has just mentioned, we have to link this with antibiotic stewardship for this test to be able to change more significantly behavior. I think also procalcitonin might be useful in here in terms of making sure that there's no concomitant bacterial infection at the same time, and we're currently studying that. Third topic, surgical site infection surveillance. You all do that? Raise your hand. Okay, a little bit more than UTIs. Whenever you get an infection, you look to see the prophylaxis is correct or not. So that's what we do, and this is our software. And so for every surgical site infection, we look at that prophylaxis. Was it indicated? Was it the right choice, the right dose, the right timing, and the right duration, as for the other antibiotics? And this is the results of 5-year worth of surgical site infection report. This is another poster that will be presented by Susan Rachel on a specific aspect. But you can see the first problem we had in the first column is having documentation of the prophylaxis. So we had to do a lot of reminders, and we now have documentation in over 95% of cases. Then you have the right dose, the right choice, so that you can see with the feedback improved to close to 90%. The right dose, you can see at one point only about 55% of patients were receiving the right dose, so they were largely underdose. The right timing, we had a lot of issues with that, antibiotic being given after incision. especially vancomycin when it was needed. And finally, duration, that was the ward that I told you had antibiotics lasting for a week, and we're close to, we're close to 100% right duration now. Well, what's the impact on surgical site infection? Well, this is our rate over the last 4 or 5 years, and you can see that last year our rate has gone down below 1%, which we're quite happy, and I think we can link it partly at least to improve prophylaxis. So this was an example of evaluating your prophylaxis in cases of infection, but you can also look at all the cases that are given, not only the infected case. So this is a big study we did, which shows 50 charts in a month of each surgical services to look for appropriateness. And you can see the first results in blue. Big problem with dose. The dose was incorrect. It was correct in only 8% of cases, 18% of cases. The agents only in about 2/3 of cases. Timing, again, poor in 30%. Duration, only in 62%. And re-administering the dose was required in about 1/4 and done in only 20%. And so what we did is we reported each of these service back to the chief and all the surgeons involved, and then we repeated the prevalence after the feedback, and in red you see the improved conformity. And overall, you can see that we went from an overall conformity of 55% to 77% pre and post intervention. So this was done largely by pharmacists, but certainly was initiated by the data that was generated by the infection control professionals. Lastly, but not least, as Dr. Jérôme just mentioned, it's nice to know what are your pathogens. And this is our pathogens in cardiac surgery, where we had elevated rates of infection, work done by Connie Patterson, who's here at the meeting. And for those who don't remember your micro, blue is gram-positive, red is gram-negative, and green is Pseudomonas. And the reason I show these rainbows is you see that in our center we had a lot more gram-negatives in our surgical site infections, and we were giving only cefazolin at that time, and we felt we needed better gram-negative coverage. We're a tertiary referral center, so a lot of patients come from other hospitals where they're colonized with gram-negatives. So we changed our prophylaxis in 2013 to cefazolin, and we added gentamicin, 1 single dose for better gram-negative coverage and to cover the Pseudomonas. And look at what happened at our surgical site infection rate. We're finally below the 5% combined leg and chest wound infection, and there seems to be a direct correlation with our prophylaxis introduction. Finally, I'm going to come back to C. diff. This is CNIS data, and you can see that the rate of C. diff in Canada has been dropping down quite significantly. If you remember, the Quebec rate I quoted you was like 20 per 10,000 patient days. We're now down to around 4, a little bit less than 4 per 10,000 patient days, so great success. But the CNIS group also correlates antimicrobial usage, and look over the same years, the decrease we've had in quinolones. And we're not the only one in the world. The British have found the same thing. There seems to be a fairly nice correlation between decreased fluoroquinolone usage and decreased rates of C. difficile. And we can even show that this decrease parallels the decrease in the NAP1 strain, which was the strain causing the outbreak, which was quinolone resistant and likely being selected when we were using quinolone as a first-line agent for all sorts of infection. So I will finish with the 10 commandments. We should not use antibiotics before dental procedure to prevent endocarditis or prosthetic joint infections. We should not treat asymptomatic bacteria. We shouldn't do cultures when we don't suspect infection, and not do all sorts of cultures like vac drain cultures, like was just mentioned. Remember that most patients need a rest of antibiotic by day 7. Look at your cultures and results. I'm surprised how often these go under the radar, and probably that's one of the areas that stewardship is very good, is they do look at the cultures. Amazed at how often we use antibiotic just in case. So, you know, all those viral respiratory tract infection, well, you ask the doctors, why are you using antibiotic? Well, just to be safe. We shouldn't use antibiotics more than a single dose or 24 hours post-op. And finishing your antibiotics used to be something we were insisting, but it does breed resistance. And follow the guidelines that you have, and especially look at your profile in your hospital so that your guidelines are adapted to what you have. So I'll conclude is very often when you start, well, everyone does what everyone is doing, but find the black sheep that will help you show the way. And well, an idea is very nice, but it's better when it's put into action. Thank you.
Thanks a lot. We have time for 1 or 2 short questions. Someone has something to ask? I was just wondering, because I saw on your slides that your team is making a round in the wards and checking the treatments, the prescription. How many times you do that per week or per month?
So the infection control professionals don't do the audits. Those are pharmacists that do the audits. What we do have, because the pharmacists will do the rounds on the wards probably 2-3 times a week, but they sit down with the infection control officer or the doctor responsible for stewardship. They sit down together for about an hour a week. Because obviously the cases of hospital-acquired infections are often some of the cases that are antibiotic. So we do a combined round between the ICP, the pharmacist, and the ID infection control officer.
Hi, I'm Misty Malott from the First Nations and Inuit Health Branch of Indigenous Services Canada. I'm actually just wondering if you've seen any successful antibiotic stewardship programs done in the community. I work with First Nations communities, and in the context of nursing stations where a patient will come in, the nurses will evaluate the patient. They will call a physician at a distance and give them their evaluation. The physician prescribes. The antibiotic is given from the dispensary, from the nurses. If there is any cultures done, it'll go to a provincial lab, and the community doesn't get the results back. And so I guess that's it in terms of community surveillance, particularly when it crosses jurisdictions, and we're looking at band councils, federal government, and provincial partners all working together.
Yeah, very good question. And I talked mostly of hospital-acquired use of antibiotic. In Canada, we actually have very little done in terms of surveillance, audits, and feedback in the community. It's by no chance that Alberta is the province with the least antibiotic consumption, because they've had a massive public campaign on proper antibiotic usage in the community. And so certainly in Canada, lots is to do. I would tell you in France, what they've published is quite amazing. They've had large number of audits in the community with feedback, and they have actually been able to show decrease of antibiotic usage in their primary care area. And certainly antibiotic usage in the northern communities is a significant problem. And as you quote, timely access to lab is a significant issue and a significant hurdle, absolutely. By the way, Misty is one of the ICPs who worked with us and collected some of that urine data that I just showed you.
Just the last question.
It's not questions, rather a comment. Regarding your last quote of Buddha, it's rather easier to divert a river than to change the behavior. I would say that if you consider changing behavior a challenge, turn your challenges into opportunities. It's not easy, but possible. I believe in motivation.
You're absolutely right.
So it's time to thank our two great speakers. Thanks, Jérôme and Charles, for your nice talks, and thanks to you for listening and your question. We have now the lunch break, and the poster visit is on the 4th floor. Thank you very much.